minutes to let some other people join and also for us to set things up.
Cool. So, hi guys. Thank you for joining our teaching session today on neurology. So I'm Catherine, and we'll be presenting with Yi as well. As usual, it's just 10 SBA style questions. We'll present 5 each, and we'll give you about 30 seconds to answer each one with an explanation. If you've got any questions, just pop them in the chat, and we're happy to answer them if we can. All right. So let's get started. So today we're going to cover different types of things in neurology. We tried to make it as high yield as possible and relevant to your exams. So we're going to talk about different types of stroke, the risk factors and the management. We'll talk about seizures, classifications, causes and treatment. We'll talk a little bit about MS, its presentation, diagnosis and treatment. We'll talk about Parkinson's disease, diagnosis, management and medications, and we'll talk about headaches and the neurological examination as well. So let's get started with the first question. So, a 74-year-old man with a history of hypertension and AF presents to the emergency department with sudden onset right-sided weakness and expressive aphasia. He arrived 45 minutes after symptom onset. A non-contrast CT head shows no acute hemorrhage. His ECG shows AF with a ventricular rate of 88 BPM, and his blood pressure is 178/96. What is the most likely underlying mechanism of his stroke? So I'll give you about half a minute to sort that one. Yeah, so if we go to the answer. So the answer is B. So the answer would be an embolic infarct from cardiac source. Well done to those of you that got it right. If we just go on to the explanation. So the patient's AF and the sudden focal neurological deficit are what is suggestive of a cardioembolic stroke. So those kind of result in cortical signs, so things like aphasia, like not being able to speak properly, or visual field defects. So kind of like that tunnel vision thing is kind of what you would see in your exams quite commonly. So the CT being normal early on doesn't exclude that they've got an ischemic stroke. So they can have the symptoms, but you may not be able to see the effect of the ischemia kind of on the CT straight away. So small vessel strokes are usually causing kind of pure motor or sensory deficits without those kind of cortical visual change or kind of speaking signs. So you kind of get that classic right-sided weakness and things like that. And watershed infarcts are associated with like low blood pressure or not perfusing their organs properly. And that's all not the case here. So it kind of generally points to the cardioembolic source. And often, if you're presented with this kind of thing, AF is a major risk factor. So if they're mentioning it, then think about it. Nice. So if we go to the next question. So kind of leading on from that, but I may have also given you a bit of a red herring there. Which of the following is the strongest modifiable risk factor for ischemic stroke? Cool. So let's reveal the answer. So the answer here is hypertension or high blood pressure. So hypertension is the most significant kind of modifiable risk factor for actually both types of stroke, so ischemic and hemorrhagic strokes. If we just move on, yeah, perfect. So that means that chronic high blood pressure is kind of the thing that puts people at risk of stroke as a modifiable factor the most, because it damages the blood vessel walls over time. So that means that it accelerates atherosclerosis, makes the walls more sticky. It increases the risk of small vessel disease, and it also increases the risk of vessel rupture causing hemorrhage as well. So it increases both of those risks kind of equally. So AF, smoking, diabetes, and hyperlipidemia all contribute to stroke risk, but hypertension is the most prevalent across the population. So those people that don't smoke may still have high blood pressure, but obviously the smoking risk wouldn't affect people that don't smoke. So yeah, it's the most prevalent a lot across everybody, especially at population level. So that means that effective blood pressure control is really, really important, especially in the community, because it really significantly reduces population stroke risk. So if we go to question 3. So a 64-year-old man presents 1.5 hours after onset of left-sided weakness. The CT hedge confirms no bleed. What is the next best step? Yeah, so if we just move on to the answer. So the answer here is alteplase or some sort of thrombolysis. So the important thing here is that if you're going to thrombolize somebody, it needs to be within 4.5 hours of their symptoms kind of presenting. So if we move on to the explanation slide. So this patient is presented within 1.5 hours of their symptoms presenting. So they're well within that 4.5 hour window for the thrombolysis with alteplase. The important thing is as well is that they should have had a CT scan that excludes the hemorrhagic stroke as well, because obviously if you're going to thrombolize them, then you're going to make their symptoms worse. So those two together would make him eligible for thrombolysis, and that's the gold standard treatment here as well. So alteplase is a tissue plasminogen activator, and that dissolves the clots. So it's the first line treatment for eligible patients with ischemic stroke, acute ischemic stroke. So it needs to be within that 4.5 hour window. And the sooner that it's given, the better the outcomes, because obviously time is brain in stroke. So we'll talk through the other options. So some people answered aspirin. So aspirin is used after 24 hours post thrombolysis, or as first line if thrombolysis is contraindicated, or if they've come outside of that 4.5 hour window. So that would be the thing that would really trip you up in your exams, like if they've come maybe 6 hours afterwards. And clopidogrel is generally used for secondary prevention. So after somebody's had a stroke, then we'll put them on clopidogrel to try and prevent another one. We wouldn't do an MRI because as MRI is more sensitive for detecting kind of ischemia in those early stages where CT wouldn't pick it up. As long as we've ruled out that they're not having a hemorrhagic stroke but have ongoing stroke features, then we can go ahead and give the alteplase because we're happy that they're not hemorrhaging from somewhere. And in this case, we don't need to do a neurosurgical referral. They would come in under the stroke team because they've got an ischemic stroke. But the times that we'd involve neurosurgery is when they're having like a hemorrhagic bleed or a stroke that's kind of causing a midline shift or significant symptoms on the CT scan, and they might need kind of surgery, maybe like a decompressive hemicranotomy, which isn't relevant in that case. But yeah, like you said, the MRI would be better to follow up the stroke's progression. So especially the ischemic progression after the first 48 hours. But in the acute phase, then we'd be going straight for the alteplase. Amazing. So question 4. A 24-year-old woman experiences an episode of lip smacking, staring, and unresponsiveness for about a minute, followed by confusion. What kind of seizure is this? Cool. So if we just move on to the answer. So this is a focal impaired awareness seizure. When I was in medical school, I used to find it really difficult to kind of sometimes tell the difference between the two. But with this one, the thing that's really giving away that it's a focal impaired awareness seizure is that this person's showing automatisms. So the lip smacking and the staring are those kind of two things there. So if we move on to the explanation slide. So the focal impaired awareness seizures, in some older questions, you might see that they're also called complex partial seizures. They're just the same thing, but they've just been renamed, as most things are in medicine for fun. I don't know. So these seizures originate in one side of the brain, so one hemisphere, and often they kind of come from the temporal lobe. So when you have a seizure that's originating from the temporal lobe, they often involve those automatisms like we were talking about. So lip smacking, hand movements, and also impaired consciousness and confusion afterwards as well. But the main thing to look out for are those automatisms that will be the dead giveaway. So the distinguishing features and why it wasn't one of the other kind of seizures, absent seizures, they often occur in children. They're usually very brief as well, and then don't cause confusion afterwards as well. A generalized tonic-clonic seizure is kind of the classic TV drama kind of seizure. So they involve a full loss of consciousness and bilateral kind of shaking convulsions, and not the automatisms that we've seen. Myoclonic seizures, they're kind of like brief jerking motions without necessarily a loss of awareness. And the atonic seizures is where you lose kind of all of your muscle tone all of a sudden, which can lead to falls, and again without kind of automatisms and things like that. So it's most likely a focal onset impaired awareness seizure. Okay. Cool. So the last one from me, a 38-year-old man with known epilepsy is brought to the emergency department by ambulance. He's had a generalized tonic-clonic seizure lasting over 10 minutes and has not regained consciousness between episodes. He has received high flow oxygen and IV access has been established. What is the most appropriate next step in his management? Cool. So if we just move on to the answer. So the answer here is IV lorazepam. So we'll just move on to the explanation. So this patient is in status epilepticus. So they've been seizing for 10 minutes, and a status epilepticus is defined as a seizure that lasts for more than 5 minutes. So that's kind of the basics of what's going on here. It can also be defined as recurrent seizures without any recovery in between them. So he hasn't recovered within his seizures and he's been seizing for 10 minutes. So this guy's in status epilepticus. So in terms of the management of status, the first line treatment is if you've got IV access, it would be IV lorazepam, 4 milligrams. If you haven't got IV access, like if you're in a GP or like, I don't know, you're out in the community, then buccal midazolam or rectal diazepam can be used as well. So second line, if that doesn't work, then you would start your longer acting kind of anti-epileptic drug. It would be IV. Usually most of the guidelines tend to say phenytoin, but there's a few more options on there as well on the NICE guidelines. And then if all of that doesn't work, you need to start thinking about calling anesthetics early because their airway would be at risk. So you need to start calling them to start kind of thinking about the ICU pathway, kind of sedating them with propofol and supporting their airway, tubing them. But that would be something that you would need to call somebody about rather than you trying to be a hero on the ward or anything like that. Fine. So if we move on to use section, there's no questions.
All right. Yeah, I think if there's any questions that come stream, then Catherine should be happy to answer them in the chat as I go along. So this next question is asking which of the below clinical examination findings is specific to idiopathic Parkinson's disease, and the key term over here is specific. So if I let you guys have some time to get the question and see what answers everyone puts down. All right, so I think we've already got quite a mixed bag of answers over here, and yeah, I think I can see why some people put some of these answers. But if we go to the answers over here, it's actually C, which is a REM sleep disorder, which is specific to idiopathic Parkinson's disease. And the next few slides will probably explain why that is the case, as Parkinson's is something that can either be rushed or go into so much depth in medical school that it gets really confusing either way. So what is Parkinson's? Well, we must first know what is Parkinsonism. So Parkinsonism actually describes a group of symptoms listed as the follows. They must have a shuffling gait, which is where they have an arm swing and it's almost like they're hobbling down one side and losing their balance while stooping forward, like the gentleman in this picture. When they get to a wall and you ask them to turn around and come back to you, they do something where turning on the block, where instead of Catherine, you're gonna get her back. Where instead of turning around one motion, they have to step their foot one at a time to face you. They can have a tremor which is only on one side and is fire and pill rolling. Basically, a tremor kind of looks like they're rolling a pill between the fingers or a coin, something like that. And it only appears on rest. So if you ask them to do something with their arm, it suddenly disappears. And when they don't do anything, it just comes back. Cogwheel and lead pipe rigidity are actually a singular term to describe the rigidity as well. Lead pipe basically means the upper part of the shoulder here is quite stiff. Cogwheel means if you try to do your tone exam and move it around and move the arms around, it feels like very stiff cogs that haven't been oiled for quite a while. And as I mentioned earlier, they're in a stoop posture, like they're almost losing their balance. It is a feature of idiopathic Parkinson's disease, but other conditions can cause Parkinsonism. And this is very important to rule out before you commit to a diagnosis of idiopathic Parkinson's disease. So medications can cause this, so especially dopamine antagonists, as they inhibit the motor pathways and the thalamic pathways from the basal ganglia. These include some dopamine antagonists, antiemetics like metoclopramide, and typical antipsychotics like haloperidol. You have a group of specific syndromes called Parkinson plus syndromes, and that's basically trying to describe Parkinsonism plus very extraordinary clinical signs as well. The most common that we think about is Lewy body dementia, where they can get hallucinations and dementia, of course. However, you can get other conditions such as PSP, CBD, and MSA. Wilson's disease, where you get excessive copper buildup, certain toxins like carbon monoxide poisoning, patients recovering from encephalitis, and a few of the other conditions that I've listed in the bottom here, which are a lot rarer, but they can pop up from time to time. In terms of specific to idiopathic Parkinson's disease, it requires quite a specific examination and must be made by a specialist neurologist. But certain features to try to obtain from the history and clinical examination was what we call REM sleep disorder. And that's when the patient is sleeping in their REM phase of sleep, they suddenly can reenact their dreams, which is often quite violent. So they thrash around in violence, and in the history, if they have a partner that they sleep with, they will normally describe that they're very aggressive and they have a hard time getting in bed and waking up suddenly in the middle of the night. They can have a sudden mood changes with depression or even psychosis. They may be drooling more often before. Autonomic features, which are parasympathetic problems such as constipation, orthostatic hypotension, which is a cause that you need to rule out. Erectile dysfunction and excessive sweating can be a feature of it as well. Amimia or hypomimia basically means an expressionless face, which looks like a mask, which is why we call mask-like faces, like in the picture over here. Micrographia, where they sort of try to write their names or draw a picture, but it's very tiny and illegible at the same time. And they can even present olfactory losses. Again, these are very non-specific, but if they have one or a combination of these alongside Parkinsonism, it sort of leads more towards a diagnosis of the idiopathic Parkinson's disease. Management is quite multidisciplinary. It involves a lot of inpatient and outpatient Parkinson nerve involvement alongside the neurologist doctor, occupational therapy and physiotherapy, speech and language, dietitian, and even some counseling, psychiatry, liaison for mood as well. Medication-wise, we the aim is to stop the progression but not cure it. So we need to give these patients dopamine to make sure that the dopaminergic motor pathways are active again, which is why we give levodopa and cocardopa. Over time, these effects can wane, and that's why we can supplement the treatment with other types of medications that can prevent the breakdown of dopamine or promote its production, such as MOAB inhibitors and COMT inhibitors as well. And just a reminder, I put a big text over here that to avoid dopamine antagonists such as haloperidol or metoclopramide, if you need to prescribe those for a patient, as you want to make sure they don't have Parkinson's and it can get worse. So moving on from Parkinsonism, hopefully that's a summary of what is going on, and you can take the time to read the slides in the recording. This next question is seeing a 20-year-old male coming into the emergency department after his parents are concerned that he was not able to move his legs. He had some diarrhea 3 weeks ago following a takeaway that he ate that has gone bad in his university accommodation. He has since then noticed some numbness and weakness that has traveled to both his legs and now reaches his thighs. It's starting to come to his fingertips as well, which is quite concerning. He has no past medical history, drinks 7 units of alcohol a week, no smoking or illicit substance use, or any family history. Examination reveals any hypotonia, reduced power 2 out of 5 for both his limbs, and 3 out of 5 on wrist flexion and extension. He is also hyporeflexed on his lower limbs with sensory disturbance too. Based on this, what is the most likely diagnosis that comes to mind? Okay, that was quite fast. I think that was everyone in the chat as well. So if we look at the answer here is Guillain-Barré syndrome, which the majority of you answered, so that's a very good job. It's quite a classic history in this case. So Guillain-Barré syndrome basically is an ascending inflammatory condition which involves the breakdown of the myelin sheath along the nerve endings and the nerve roots as well. That interrupts the transmission of action potentials and therefore delays the sensory and motor functions that we can see over here. It mainly affects the peripheral nerves at most. This is mainly triggered by infection, most commonly Campylor jejuni, which is related to food poisoning, but can be triggered by Mycoplasma pneumoniae, Epstein-Barr virus, and recently found COVID-19 can also trigger Guillain-Barré syndrome. And there are quite a couple of case reports they can find in various journals reporting this as well. When an infection like this triggers it, your body produces autoantibodies called autogangliosides, and these break down the myelin sheath, as I mentioned earlier. Symptoms are mostly symmetrical ascending limb weaknesses, so you get it both on the right and left side of your body, and it goes up gradually over time. This can cause lower motor neuron symptoms, which is hypotonia, hyporeflexia. Basically, your whole body goes limp as well. And if it does get up to a certain point where it's not reaching your chest, it can cause a respiratory failure where it interrupts your breathing as well. You mainly want to investigate a source of infection for this to try to rule out and reverse. But you also want to do the antibody test to detect the antibody, as I said earlier, a lumbar puncture with a specific result, and nerve conduction studies to see if the conduction of nerve signals can be transmitted all right. Immediately, you want to give some immunoglobulins just to try to get rid of the antibodies as well. You want to treat the infection, and you also want to get them undergo plasmapheresis, which is like dialysis, but it's to try to also further remove all the bad antibodies out and to try to reverse the damage as much as you can. If breathing is interrupted and type 2 respiratory failure, you need to monitor their vital capacity quite closely and give them respiratory support and protect their airway where it's important. So this next question over here talks about multiple sclerosis, but it asks which one of the following is not a feature of MS. give you guys some time to think about this one. Right. Any last two people want to answer? No, that's fine. Actually, I think I don't know about you, but I think Catherine and I thought this was probably one of the hardest, if not the hardest question in this whole pack. But I think everyone actually got the correct answer for this one, which is Rhizus sardonicus. So well done, everyone, actually. Now, as a bonus point, what condition is this most likely associated with? If someone is brave enough to type it in the chat to give it a punt. Tetanus, yeah, fantastic, yeah. And the reason it's called Rhizus sardonicus is Rhizus is smile, sardonicus is quite a evil grin as well. So, which basically means that it's smiling almost in an evil nature, which is shown in this picture over here, and that's a very classic sign of tetanus infection as well. So, what is multiple sclerosis actually? It's a chronic condition and it's also an autoimmune condition. And again, like Guillain-Barré, it causes demyelination of your myelin sheath in your central nervous system. But this is more of an autoimmune response rather than something triggered by infection. It's unlike Guillain-Barré, where it affects the peripheral nervous system. Multiple sclerosis affects your central nervous system, so that is a very important distinction to make. It has a higher incidence in females, a mean onset of 30 years, so it affects quite young females as well. And debatably, you can see in some textbooks that it affects more women of Scottish descent as well, but that's a highly debatable thing in the prevalence of the disease. There are two types of MS that you need to be aware of, but the one that you really tend to be examined most of is relapsing remitting, which is mostly appears in younger people. It basically describes them having these symptoms come in attacks in 1 or 2 months before the symptoms suddenly resolve and they don't have anything, and then it comes back again. So it's something that you need to observe and make sure and track how many attacks they have. So what are the symptoms of multiple sclerosis? They mainly will have upper motor neuron signs as it affects the central nervous system. And they will have paresthesia as well, particularly in a patchy fashion, which basically means that unlike Guillain-Barré, where it's very symmetrical, it's on the same side on both ends, you can have a bit of numbness here, a bit of numbness here, a bit of numbness everywhere. It's all very random, which is why we say it's patchy for this. A classic sign of MS is optic neuritis, which is a loss of central vision and pain on eye movement as well. So anyone with optic neuritis, you probably want to screen for MS as well. Transverse myelitis, which was what we described, basically means a hugging tight feeling around your waist as well, which is classically associated with MS. You can get ophthalmoplegia as well, which you can get a nystagmus for on that. Unto's phenomenon, since everyone's able to answer that correctly and rule it out, does anyone know what that actually means? It's alright if anyone doesn't know, because I only found out about this recently myself. No, that's alright. So basically, Unto's phenomenon is a phenomenon where if the person with MS is exposed to hot environments like a hot weather, a hot shower, or exposed to spicy foods, that symptoms can get triggered a lot more. And that's because heat can promote these action potentials to rush through these broken nerve endings of the broken myelin sheath. So the action potential just builds up. So therefore, your symptoms get exacerbated from there. On top of all of this, your main investigation finding that's specific to this is an MRI head, and you get something called dorsal fingers, which you can see in the picture here, and that's very dense projections coming from the corpus callosum, which is the structure that's in the middle of the brain over there, and that's very classic to MS as well. They kind of look like little fingers coming up. Basically, with anyone having these MS attacks, you want to treat them with plasmapheresis like Guillain-Barré, and you want to treat them with lots of steroids to reduce inflammation as well. Then you want to give them some therapies on the long term to try to control these attacks called disease-modifying therapies as well. And these are quite specialist drugs such as beta interferon, which are only prescribed by a specialist neurologist as well. And you just need to keep monitoring them for quite a long time and have ongoing MDT input to try to support them as they try to manage the condition throughout their life. That's quite life-changing. Yeah, that was quite a long talk for MS, but on the second last question over here, a bit faster, a bit more easier. A 60-year-old woman has started to complain of persisting pain and numbness, initially starting on the back of her neck. She currently describes a loss of sensation around her little finger and has noted that she struggles to grip objects or attempts to make a fist. You suspect a cervical disc herniation, but based on these symptoms, where would the most likely location be before you decide to peek into the imaging and find a radiologist report? Okay, yeah, there's some hesitation for this, and I think I included this because some spine stuff can get missed during medical school teaching, so might as well cover it over here. Give it another 10 seconds for any last minute answers before I move on. All right, so for three answers, I think there's some very disagreements between this, but the answer over here is C7 and T1. And I'll explain why, because there's actually a few layers of thought in this. So, before I go into it, you want to have a look at the symptoms that she's having. So, it's in the back of the neck, so you know somewhere in the cervical region. And you want to look at the loss of sensation around her finger. So, you might be suspecting that's a dermatome being affected. So, to go through the dermatomes roughly on camera, basically, your C5 dermatome, it covers just about the shoulder over here. Your C6 covers everything up to your thumb and index finger. C7 only covers a little triangle of your middle finger and a bit of your palm here. C8 covers your ring finger and your little finger over here, up to just a little bit over there. T1 covers this portion here, and T2 covers just under the armpit. So you can use dermatomes to try to work out where the loss of sensation is. But when you noted that she struggles to grip objects, that's also quite a function of the C8 dermatome, as she's unable to flex and extend her fingers. The way I try to remember it is a dermatome dance, which I know some people have heard or some people have not heard. So basically, C5 is where you do your elbow flexion and your wrist extension. So it's like you're shrugging your shoulders like that, and you put your shoulders up as well with a shoulder abduction as well. Then C6 is what you call zombie a bit. Then that's where you extend your shoulders and you extend your elbows as well. Then C7 is where you do this. C8 is where you flexion and extend your fingers. And T1 is where you AB duck and AD duck your fingers as well. So if you kind of look on YouTube or something, someone can do the dermatome dance for that as well. But at least you now know it's C8 that's been affected over here. The next bit is where the lesion could be, and there's a general rule to follow for spine as well. Um, your in your lumbar spine, that's the one that's easier. Your nerve root in question is usually the level below of the vertebrae they're looking at. So if you're looking at L4 nerve root being affected by a lesion, you would expect it to be somewhere below L4. So the space would be L4, L5, for example. However, for the cervical spine, it's the opposite. You expect it to be above the level. So if it's in this example a C7 lesion, you expect it to be above the C7 root. And the next bit of train of thought for this to make everyone aware of is that there is no such thing as a C8 vertebrae. You get C7, and that's the end of your cervical spine. You immediately go to your thoracic and T1. So why did they name it like this? I have no idea why. Probably just outdated stuff that's annoying to learn, but that's a rule that you just have to remember for this sort of thing. So there's a lot of layer of thought to this, and that's why I kind of shared it to you guys to help you guys understand the depth of working things out like this. And the very final question, we go back to yourself being in A&E, and you see a 55-year-old man presenting to his GP. He states that he has ongoing recurrent episodes of severe headaches over the past month. He describes the pain that's excruciating around his right eye, and each attack lasts about 45 minutes, about once or twice a day. It wakes him up from sleep as well, which is quite excruciating. He reports right-sided nasal congestion, lacrimation, and bright eye, watery eyes during these episodes on the right eye. He denies nausea, phonophobia, and despite using as many analgesics as he can from the pharmacy, he doesn't find any relief from this pain. His past medical history includes asthma, contact dermatitis, and previously COVID-19. He is a current smoker of 15 cigarettes a day. Between attacks, his neurological examination is normal. Which of the following is the most appropriate acute treatment for what you think this condition will be? And I think while everyone's trying to answer, I think I did a little bit of mistake with the dermatome dancing. So C5 is when you abduct and you swing your arms like that, and this is C6 and that's C7. So I do apologize if anyone got a bit confused with that. Let's give another 10 seconds before I move on for this one. Yeah, so for this question, everyone chose B for this one, and that is the correct answer. So, is anyone able to tell me what condition we're thinking of that's going on? Yep, Olavato has hit the bell on the head. It's the cluster headaches that we're dealing with in this situation. Um, yeah. So what are cluster headaches? Cluster headaches are excruciating, painful unilateral headaches, so they only happen on one side. That typically was around the eye in this case. The group of people that are most at risk of getting a cluster headaches are males, as one, that are above 50, that's two, and who have a excessive smoking or drinking history, like in this case as well. And clusters can occur several times in a week, and they can appear a lot of time once a year as well. They can go away by themselves for an extended period of time before they come back all of a sudden. So it's a hit or miss diagnosis at the same time. It's a, Patients who describe cluster headaches tend to describe it as a very significant stabbing pain around the eye, and they can get quite restless and agitated due to the excruciating pain. A classic examination finding, if you look into the eye, is that it's bloodshot and it's very teary as well, like in the picture over there. And they can get nasal stuffiness as well with the condition. Diagnosis is based on the clinical history itself, and due to this, the acute attacks are usually treated with high flow oxygen and subcutaneous sumatriptan as well to try to relieve the attacks. Um, to prevent these attacks from coming again in the future, verapamil is usually used as a prophylactic medication in the long term. Um, if that's contraindicated, they can opt to prednisolone tapering their steroid medications down, and they may require neurology follow up to follow up this case as well. And that is the last question. And I guess this is just a very short slide just to see about what type of headaches you guys should focus on, at least in this level, just to make sure that you're ready for whenever some of these presentations come up and you're aware of these conditions as well. And that's the end of the session. So I guess my tip would be to go over the difference between upper motor neuron lesions and lower motor neuron lesions as well, and look into your neurological examinations as well, as they can put out the techniques for each. Just remember to go through your tone, your power, your motor function, your sensory function, and any special tests that you need to go for that. Um, Catherine wants to add anything else? Or
Yeah, just make sure that you know cranial nerves as well. They're quite commonly tested both in OSCEs and also in med school finals. So make sure that you know what each one does and kind of what the special tests are. Just practice getting them under 10 minutes if you haven't done your OSCEs as well. Because that caught me out. They asked me to do a full cranial nerve assessment and that was pretty difficult. But yeah, if anybody's got any questions, then let us know.
yeah, and as earlier as well, to cover your dermatomes and myotomes as well. And if you have the time, your peripheral nerve territories, but that's a bit harder from that bit. But yeah, I think we're just going to be staying for the next 5-10 minutes, in case anyone's got anything to ask. Let's try to get the feedback out over here. If everyone's able to fill that in, it will be greatly appreciated.
Yeah, it's really helpful if you can fill it in, even if you're watching it as a recording as well.
All right, thanks, guys. I think we'll be just ending the session right now.